all my instructions here. I want to thank everyone, or thank the committee for the invitation to present today. I'm here from representing San Diego, California, where it's nice and sunny, and of course it is here as well. And I'm looking forward to checking out your city to see all of the wonderful sights and the culture that is in front of me here. I tend to be an interventionist, and my goal is to work with patients to prevent diabetes. And in San Diego, I have 3 clinics weight loss clinics that I run with an internal medicine doctor. So I just want to share with you today a tool that I decided to use based on some funding I received from the School of Nursing in San Diego to identify or to screen my patients to see how many were truly at risk for prediabetes as they had not been screened. So I think we've talked enough today about just certainly the prevalence of diabetes, how it certainly is a global issue. And when you consider that more than 80% of diabetes deaths occur in low and middle income countries, and that is going to be our 7th leading cause of death, supposedly, by 2030. As clinicians, we have a big task in front of us. Just a little background. The CDC estimates that 1 of every 3 adults had prediabetes in 2012, and that's over 79 million Americans who are 20 and over. And although 37% of US adults have prediabetes, it's astonishing that only 11% of those with prediabetes are aware of it. Looking at some of the evidence of why it's important to screen, or how we do screen, I referred to the US Diabetes Prevention Program research trial that was led by the NIH and was one of the largest lifestyle intervention studies to assess prevention of type 2 diabetes. And what they found, this is certainly just a little summary, is that in the lifestyle intervention, those patients experienced a 58% lower incidence of type 2 diabetes than those who did not receive the lifestyle intervention. What I liked about the study and the simplicity of the approach that was used is that there are 2 main or 2 main goals for our patients. That was to lose 7% of your body weight and to exercise a minimum of 150 minutes a week. Years ago, I would tell my patients, oh, the studies say that you have to do about 300 minutes a week for it to be effective in losing weight. And of course, that turns everybody off right away because no one has the time or energy or really wants to jump in that quickly. But if I presented that, this means if you take 2 15-minute breaks during the day and go for a walk, you can achieve that 150 minutes. Most of my patients will say, yeah, doc, that is doable, and it's hopeful for me. So this just showed that from a national sample of US adults who were 18 years and older, the CDC screening test, which is what I used, correctly identified 27 to 50% of those with a score of 9 or higher as true cases of prediabetes based on either A1C, fasting blood sugar, or 2-hour oral glucose. So the purpose of my study was to examine the ability of this simple 7-item prediabetes screening tool to identify at-risk prediabetics and to look at how my patients responded. And I felt it was just important to see, how easily, or do these truly predict prediabetes, and how easy is it to implement this in a busy clinical practice. So we tend to see 300 to 400 patients a week at our clinics. And patients come in for about a 20-minute visit weekly or every other week, and they're provided with support, behavioral support, and support to change their lifestyle. So the methods that we used were just to draw an A1C if they scored greater than a 9 on the CDC questionnaire, which I'll show you in a minute. If they did score greater than a 9, I offered them the 16-week diabetes program. And it's very difficult to get patients to come in and do groups, so I decided just to be realistic, and I actually just gave them the material to read on their own. And when they came into the clinics and were weighed, our main focus again was to assess how many were achieving the 150 minutes of exercise, and at 4 months, our plan then was to repeat the A1C and to look at their progress. So again, the goals were very simple for patients. This is the risk survey. And basically, what it comes down to, if you're over 45 years of age and you're a little bit overweight and you don't exercise, that's such an easy way, it seems, to screen for prediabetes. So a score of greater than 9 indicated that they were high risk for prediabetes. Many of my patients still had normal blood sugar levels, so to add this additional screening tended to be just a very nice motivator. So it's a relatively small sample of only 70 patients. They were primarily women. The majority of them were obese and primarily females. I had a mixed group as far as ethnicities. This just shows the chart of the level of obesity. And in our results, we found that those who had a survey score of greater than 9, of course, 100% were at risk for having prediabetes. And based on the A1C, which we did at that point, over 70% were in a prediabetes category. Risk scores and the A1C were correlated, and we really didn't see a difference as far as between actual elevated A1C and someone who was overweight versus obese. There was the same risk for prediabetes. This just shows some of our factors that we looked at related to increased risk. This was just a plotter graph of the relationship between scores and hemoglobin A1C. Our sample mean age was around 45, BMI was about 34. They had large waist measurements, around 40 inches. Prediabetes score average was over 12, and hemoglobin A1C average in this population was over 6. I'm in the process of doing the total 4-month evaluation, but as I just did an overview of what kind of responses I was seeing, the weight loss, two patients lost more than 30 pounds at 4 months, one patient more than 20, 21 patients between 10 and 19 pounds. And these are some of my examples of A1Cs at 4 months as far as the drop. I don't know why I didn't include it, but I did have one patient who actually was diabetic and had a hemoglobin A1C of 12, and she was able to get her hemoglobin down to a 5.6 at 4 months and was very pleased with that. Implications for practice, I just think it's very important to make our patients aware of the risk, because even though I think there's a lot of media and emphasis on the seriousness of obesity, until you really show someone that you have some evidence right here and you've got labs to show them, it seems like it doesn't really motivate a lot of people. And again, I found that this was just a very simple 9-question survey that was easy to use in about 2 minutes at a clinical setting. Limitations, of course, it's a small sample. All of the patients were overweight. There's always a problem with program retention at follow-up. I think that's true with all research. Recommendations would be nice if I could follow them longitudinally for a longer period of time, of course. Perhaps in the future use a control group. And I'm really interested in adding telehealth, whether it be text messaging or phone calls, just to help give patients the support that they need. And just some of my references. Here's a beautiful University of San Diego. Thank you very much.
Thank you very much for the beautiful presentation. It's very important that we do the screening for pre-diabetics and start early management programs. And I also would like to add a note to this. We did an extensive study with Chennai in India, 25,000 patients, and we analyzed the data with the CDC data that they have from Enhanced 3 studies, compared the BMI data of Caucasians, Afro-Americans, and the Hispanics and Asian Indians. What we surprisingly found was that all those South Asians or the Indians have a low BMI. If you go by hip-waist ratio, they are quite obese because it is the visceral fat, not the subcutaneous fat, that is important in development of the insulin resistance and diabetes. So we also had to develop our own guidelines, whether it is in Africa or India or anywhere, in terms of what we consider as the obesity and start screening for at-risk patients. Any questions for Kathy?
Thank you, Dr. Kathy. So in your practice and the pre-diabetic and put next to that is the diabetics. And I'm just curious, I'm not a clinician but a researcher, and curious about the marker of fasting blood sugar put next to glycated or HbA1c. How concordant it is in the pre-diabetic versus diabetic, in your opinion?
The correlation between fasting glucose
I mean,
and the elevated hemoglobin A1C?
Yeah, I believe HbA1c is good for like 3 months period, but how is that concordant within the daily fasting measurements in pre-diabetic next to diabetics?
Most of my patients still had normal blood sugar levels, and yet they had elevated hemoglobin A1C levels. So I feel like the A1C is a better predictor.
Even in pre-diabetics.
Mm-hmm.
Thank you.